Today we're going to talk about nightmare deliveries, and it's a week before Halloween, so it seems a perfect topic. I've been a doctor now doing emergency medicine for about 20 years, and I'm happy to say that I've never been involved in a complicated term delivery. I've seen them, but I was never the only doctor there, and I was never the one in charge of the circumstance. And I'm pretty happy about that, I gotta tell you. It's not like I want to be involved in one of those complicated deliveries. I hope actually that I get to the end of my career and I never am involved. But just in case, I think it's probably good that I review the approach to complicated deliveries, so I know, so I'm ready. Today I was lucky enough to be in Sim Lab, and Dr. Malapati and Michelle Sergio put on a Sim Lab that was about complicated deliveries. I was luckily I was there. I learned a lot, and I'm going to give you that information that I learned today. I'm going to dummy it down because she gave us a ton of information, and I'm not sure we can remember it all, but I'll hit the highlights here. This is like the worst possible storm, a complicated delivery, especially when there's no OB in-house. This is Dr. Malapati. She's the one who taught me everything I know today. And of course, Michelle, who put on the Sim Lab. All right, first let's talk about shoulder dystocia. How do you identify it? And what will you do when you recognize that you have one? Well, how do you know? You know because the head comes out and then no more comes out, despite pushing. It's because the shoulder gets caught under the pubic symphysis and the baby can't move any further. The approach to the patient with shoulder dystocia goes kind of like this. Control your own bladder. Flex the patient's hips. Flex the neck. Dislodge the shoulder. Deliver the other shoulder. Rotate the head. Break the clavicle. I should have pray on the end of this, because that should be what you're doing the entire time. Well, let's talk about them in order. First, control your own bladder. This will definitely be a frightening situation, and it's frequently associated with precipitous delivery, so it definitely can happen in the ER. What you need to remember is as soon as you see something that looks like a precipitous delivery going on in the ER, have someone call OB immediately so they know that someone's delivering in the ER. It's better safe than sorry, and as we know in emergency medicine, never carry the coffin alone. Once you got your bladder in check, you want to flex the patient's hips. The problem is that all the room is posterior and the baby is caught anteriorly. You need to open the space, shift the baby toward the sacrum, and flexing the hips may do the trick. Here's a picture that shows how the angle changes when you flex the hips. This is called McRoberts position. Not sure that's important, but if you can remember it better that way, that's great. But remember that flexing the hips opens up the pelvis and makes it easier to deliver the baby. It's easy enough, right? Next, you want to remember that babies are always delivered best if the neck is flexed. It's uniformly helpful. If the neck is extended, the angles are all wrong, and delivery is uniformly more difficult, if not impossible, not to mention the risk of injury to the baby and their neck. In general, face down is better than face up during the deliveries. Turn the baby face down or spine up whenever possible. The first thing the baby should see as it comes out of the mother is her butt. Uh-oh, the baby's still stuck. Now what do we do? All right, well now you're going to try to dislodge the shoulder. The way you do that is to press on the symphysis pubis. Press one side of the symphysis against the baby's back in order to roll the shoulder out from under it. The only person who's going to know which way the baby's back is the person delivering the baby. And the person delivering the baby is going to have to tell their helper which side of the pubic symphysis to press on. Ligaments of the symphysis are lax at this point in pregnancy, therefore somewhat mobile, so this is possible. Here's a picture showing how you push on the back of the baby and try to roll the shoulder out from under the pubic symphysis. As far as suprapubic pressure goes, it's medial pressure against the baby's back to roll and release the shoulder. Pressure should not be directly down in the middle of the pubis. Start on the side of the baby's back and push medially. Do not put pressure on the uterus. An assistant will need to apply the suprapubic pressure as you try to deliver the baby. Make sure that they understand exactly what they're supposed to do and how they're supposed to do it. Just these two actions, hip flexion and suprapubic pressure, are 80% effective in releasing the shoulder so you can deliver the baby. Uh-oh, what if it's still stuck? All right, now it gets hairy. What you remember next is if it's still stuck is you got to bury your arm because you want to deliver the posterior shoulder. The anterior one's stuck, you're going to go after the other one. Bury your arm along the posterior vagina. Feel all the way down to the baby's arm until you reach the hand. Then sweep the hand up and over the head so the shoulder can slip out, and then the anterior shoulder will follow. It's a sweeping motion, like a ballerina. Sweep across the face and up over the head. Here's a picture. They're not holding the hand here, but you get the idea. You're pushing the shoulder across and bringing the hand up and past the face in a sweeping motion. When you sweep the posterior shoulder, you don't want to have any suprapubic pressure. That's just going to make things more difficult. It's best to tell the patient not to push because you want the space as wide open as possible, and you don't need the mother to jam the shoulder even harder up against the pubic symphysis. Do an episiotomy if necessary to access the posterior shoulder. Just a reminder, the medial-lateral episiotomy is the preferred approach. Still stuck? Next, you want to gently try to rotate the head with abduction of posterior shoulder. 2 fingers are pressed against the anterior surface of the posterior shoulder to turn the baby's back up. The first thing the baby should see is the mom's butt. This is the optimal position for delivery. Still stuck? All right, now it's ugly. You want to break the baby's clavicle to decrease the diameter of the baby's shoulders. Grab the mid-clavicle with your finger. Gently pull out and away from the vessels and the lung. They break pretty easily, so I'm told. But the baby could remain stuck. What are you going to do then? Memorize the steps because they'll buy you time. Control your bladder, call OB, flex the hips, flex the neck, dislodge the anterior shoulder, deliver the other shoulder, rotate the head, and break the clavicle. These are all the things that you can do, and once you've exhausted these, there's really nothing else you can do. But at that point, you're really glad that you called OB early and they can take over. Just in general, if you have a mother in labor, call OB. Tell them you're coming. Tell them it's a multip. Tell them it's a complicated pregnancy. Tell them it's precipitous. Tell them it's breech. Tell them it's a shoulder. Just tell them. Let them decide how to react. If you don't tell them, you're delaying them coming to help you. Not a good plan, especially if the delivery goes badly. Now, what if the baby's breech? Breech presentation kind of works like this. Unless you actually see the butt hanging out on the perineum, you have time to get the patient upstairs for a C-section. You don't need to look inside the vagina. It's only if the butt is hanging out that you're stuck and you got to take care of the patient there. Footling breech, you've got time, and you do not want to deliver a footling breech vaginally. They need a C-section. Get them ready. Get them to the OR. Cord out, check the cord for a pulse. Good if they have a pulse in the cord, but not necessarily dead if there's no pulse, so don't take it to mean more than it seems. When you see the cord out, hold it inside the vagina and start rolling toward the OR. If you can push the skull and keep the head from engaging on the way, all the better. And remember, in these breech presentations, terbutaline is your friend. Slow things down and get them to an obstetrician. Now, what if the butt is out? Well, now it's on. You've got no choice. Do not pull. Turn the baby face down, sacrum up, while you still have the chance. The last thing you want is to have the baby in a breech position and then have him engage in a worse position. Deliver the legs one at a time and keep the baby in a horizontal position. The mother can push. When you have in this position, if you're pulling on the baby, you want to pull on bones. Don't smash soft tissues, the belly, the chest. You can cause internal damage that can kill your baby. So be careful to just put pressure on the bones and be gentle. I know you're going to be scared, but be gentle. Remember, in newborns, the head is bigger than the butt. So just because the butt got past the cervix doesn't mean the head is going to. The cervix may constrict around the neck as the baby passes up through. And then the head gets stuck. The worst case scenario is you're delivering a breech baby and you allow the head to be extended. Now the diameter of the head is huge and the cervix can easily grab around that neck and clamp down. If the baby's head is flexed and the chin is down, it's a bigger AP diameter and the cervix can't clamp around the neck. It can clamp around the chin, but that's not going to cause so much of a problem. You need to get your hand in there and flex that neck. As you see, the anterior position of the hand is pushing the head down a flexed position. The posterior hand goes up and puts a finger in the mouth to find where it is and to further flex the neck a little bit. Gently putting the other fingers on the cheekbones, flexing the neck and facilitating the delivery. What if you get the baby out? Everything's good. The baby's fine, and the mother starts to hemorrhage. Well, these are things you can do. With a postpartum hemorrhage, first, I didn't know this before. I always thought Pitocin was after the placenta, but you can give Pitocin 10 to 20 milligrams, IM or IV, you don't need the IV, as soon as the baby is out. The placenta should deliver within 30 minutes. And if you have bleeding after the placenta is out, first massage the fundus. Look inside for cervical tears or something you can repair. Consider giving Cytotec 100 micrograms per rectum to stop the bleeding. Remember, it's a good idea to sweep the uterus for barnacles, as one of our residents says. But by that we mean pieces of the placenta that may be along the inside of the uterine wall. I've never put my hand inside a uterus after a baby was born, but apparently it's smooth on the inside, and when you run across a barnacle or a piece of retained product, it's fairly obvious. If none of these things work, you can pack the uterus with Curlex, or I guess in OB they have a kind of large Foley, a balloon that they can put in there. I don't think we have one of those. Perhaps we should get one. But in a pinch, you can use Curlex. Definitely not 4x4s because you don't want to lose them inside. No extra foreign bodies needed. Tie the Curlexes together and start packing them in. All right, let's just change gears a little bit because I had a few news flashes that I didn't know about before as well that we might want to talk about. Newer concepts, at least newer from the time I did OB, which, now is a lifetime away. Number 1. When a baby is delivered, they get their NPO. Nothing goes in the mouth. No sweeping the finger, no shoving the bulb syringe down there. Apparently what that does is increases reflexive swallowing and aspiration. It's the worst case scenario if the baby has mech in their mouth. Don't put anything in the baby's mouth and cause them to aspirate. 2. If you have a nuchal cord, don't cut it. Once it's cut, the baby is no longer oxygenated. This is a terrible idea with shoulder dystocia. That you need all the perfusion you can get for as long as the baby can get it while you try to work that shoulder out under the pubic symphysis. If you can, pull the cord over the baby's head. It's a bungee. It's stretchy. And from what the obstetrician said, very unlikely to break when you're trying to get it up over the head. So give it a good shot. If you can't pull it over the head, leave it alone. 3. If the baby has no cardiac activity, there is no emergency. I should repeat this one. If the baby has no cardiac activity, there is no emergency. I think it's gestalt for an emergency physician. If the baby's heart stops beating, that you got to get them out even faster so you can resuscitate them. Apparently, babies give a lot of signs before they die. They don't just die. They struggle and struggle and struggle and struggle and struggle and give it a shot, and then they die. And then they don't come back. So if the baby's dead, there is no need to do an emergent intervention. Don't make things worse. Because in retrospect, someone's going to tell you you never needed to do any of that because the baby was already dead. And if something complicated happens to the mother, you're going to feel really bad. If the baby has no cardiac activity, there's no emergency. Talking about dead babies, babies that aren't dead in utero cannot be resuscitated. They don't die easy. I just said this. Once they're gone, they're not coming back. Don't go nuts and harm the mother trying to get the baby out. As soon as you confirm no cardiac activity, and that does not mean bradycardia, you only have one patient to worry about. Number 4, DIC risk. Dead babies lead to DIC, especially if the baby's been dead more than 3 weeks. Another thing that leads to DIC risk or a hemorrhage in the emergency department or persistent bleeding is a mother who has an amniotic fluid embolism. They can go into DIC immediately. But in that case, you'd see a mom who becomes shocky, short of breath, or goes into a full arrest. So it should be fairly obvious that something's up. Just remember, if amniotic fluid embolism is in your differential, DIC should be the next thing you think of. All right, as always, be careful out there and try your best to harm none. I hope you all work with the angel that I work with that has kept me for 20 years without ever having to deal with any of this in the emergency department where I'm the only doctor in the hospital. I consider myself very lucky, and I hope I continue on this path. And I hope you too never have to deal with this alone. But if you do, you'll know what to do. Good luck out there.